So the pathway for diffuse large B-cell lymphoma has changed rapidly, even in the last couple of years. So now we have a different first, second, third, fourth line option for our patients. And certainly my approach would often be first line Pola-R-CHP, second line CAR T, third line bispecifics, fourth line loncastuximab. These are my approach and what's reimbursed in the UK. There may be a time where we can truly identify the high-risk patients up front and therefore give them CAR-T in a first-line setting rather than just in a second-line setting. But there's still a lot that we need to understand about the biology of the disease as to whether CAR-T will become first-line for a few patients. The other group may be the patients who are later relapses than just that 12-month cutoff. So obviously the current indication is for patients that relapse within 12 months. But I think that we really want to obtain data as to the outcome for patients who relapse later, and also for the auto-unfit patients in that second-line setting, because both Lysocell and Axicell studies looked at auto-fit patients because it was a randomization to auto in the standard arm. We've seen data from the French ALYCANTE study where the outcomes for Axicell were very favourable, even in an auto-unfit setting. And so therefore, I'm hoping that that will become broader in terms of indications second line, and possibly with better understanding of true predictive features of high-risk patients. It may move for some patients in the first line space.